un resguardo domiciliario o si tuvieron que ser ingresados a una unidad de segundo nivel para su atención. Y lo que podemos ver también en la distribución de los grupos de edad es como a medida que la edad avanza, tenemos una mayor proporción de personas que lógicamente terminan hospitalizadas.
La situación de la epidemia diaria, sobre la situación de la epidemia.
Personas que tuvieron que ser atendidas de esta manera. En la siguiente diapositiva vemos.
Okay, next slide, please. In this next slide, we can see take a better look at this 18%, which is itself divided into different percentages. Most of the patients are stable. There's a 6% that is patients that are in severe condition, but not intubated. They're not breathing artificially, so to speak. And then the 1% has been intubated. And those are the critical, that's the critical percentage that could end up in deceased patients. Now, next chart, we can take a look at the distribution of the 36 deaths that have occurred. We see that most of them are still male and most of them belong to the elderly. They are senior citizens. In this slide, we can see the distribution of fatalities according to state. And here we can take a look at the percentage of the distribution of death according to previous conditions. So which are the conditions that are most likely to lead to complications and eventual death in the case of COVID? And the top three are still hypertension, diabetes, and obesity, of course. And I would like to mention that the 37 people who passed away all of them had at least two of these conditions, if not three, and they presented them specifically in these proportions that we are looking at right now. Now, here we can take a look at the daily update on the curve. So as you can see, today's final number is 1,378 confirmed cases, and we can see the relation between the acceleration of our curve as compared to that of other countries that are currently in the epidemic stage, in phase 3 of this pandemic, and a lot of them most probably getting close to the final stages of the epidemic, and then they will soon start to experience a slowdown in their contagion rate. But as you know, our country entered the pandemic later than these other countries, so we still have some time ahead before we can see a slowdown in this contagion rate. This other chart is specifically related to a request of information that was made yesterday at yesterday's conference, and this is the amount of people who have recovered. We're looking at a 46%, which is near half of them, and out of those people who recovered, who have a favorable evolution, so to speak, most of them were outpatients, and they were just isolating themselves at home. And we can see that these 46% can now, it is confirmed to be recovered absolutely from the virus. So this is a favorable outcome, of course. That would be the information for today. Thank you. Thank you, Doctor. Now, Dr. Manuel Cervantes, you now have the floor. Can you talk a little bit about the situation in Coahuila? Thank you very much, Deputy Secretary. Thank you, all of you, for being here. I understand, and well, in accordance with the commitment made yesterday regarding the situation in Monclova, Coahuila, I would now relate some of the decisions and information that we got this morning. This morning at a meeting that was in which the governor of the state was present, as well as the municipality of Monclova. The president of that municipality was also present, and other relevant and important authorities, including Dr. Eduardo Robles, who was yesterday here speaking to you. They had a coordinated meeting with 5 workers from this hospital in Monclova to address this issue and to convene on the most appropriate strategies to control this outbreak within the hospital of Monclova. I would like to reiterate that we take this very seriously, and all of the cooperation between the different parties involved were happening in the most professional manner. So we agree that we will undergo a sanitization process of the whole hospital. So, and when talking about the protection of personnel, today there was a shipment that came from our warehouses here to Monclova warehouses that had the necessary equipment to undergo such tasks. Also, we established a plan of training and qualification that involves nurses, nutritionists, doctors, and all sorts of health sector workers. This training program started since last Sunday, and it is in charge of a leading group of experts who will be relevated in their functions next Sunday. So it's a weekly basis. You know that these high demand teams have to be relevated in their duties every week, as you know. Another measure that we'll be implementing is having a filtering operation to know which workers are in potential risk of having been infected. I would like to thank the mayor of Monclova for all their support and all the resources that he has provided to us in this operation. There was a colleague who was above 60 years old, and we had to ask him to isolate at his house. And we also deeply lament the passing away of a very close co-worker. Now, that's about it, and we're all very ready to comply with the orders of the Deputy Secretary. Thank you very much. Thank you very much. I would like to commend and I would like to compliment all of the productive work and the productive efforts that have been the result of the cooperation between all sectors and all workers within the health sector specifically. And also we've had interinstitutional cooperation that has been very, very productive. Sometimes some institutions have a better or larger capacity or ability in any technical domain. They sometimes create a set of guidelines, and then they share it with us, and then we implement those in all other industries and sectors. And all of this, like, cooperation has been very satisfactory to us. So I would like to thank you all for this. Doctor, please would you share with us the new tool of communication and citizen orientation, please? Thank you, Deputy Secretary. Could you share with us? Can you put the slide on? Thank you. Well, I would like to relate to you the result of a very important effort, collective effort that we've done within the Ministry of Health. And this is the application COVID-19 MX, which is a tool to double down on the efforts of fighting against this pandemic on a national, on local level. So the objective of this application, of this app, is to facilitate the population in regards to taking care of their health, monitoring their health and their family's health, and being in constant communication with the health authorities of the country. So we have, as actors within the Ministry of Health, we have the responsibility and the willingness to communicate with the population and orient any citizen who may require further orientation regarding his health or his possible contagion from COVID-19. So basically, this app, what you do is you download it and then you input your data, and then we start collectively generating this gigantic database that will be of much help to us, but also to the citizens, because they can. We will also be sharing our data with the citizens, and then any of the citizens can access this information through the app. It's now available to any device, Android device. You can download it for Android devices right now, and in a few days it will be ready to be downloaded in Apple devices as well. Next one, please. Now, these are some examples of what the app looks like and some of the functions available within the app. We have self-diagnose function. We have common symptoms of on a suspicious case of COVID function. And through this app, you can know yourself if you belong to the high-risk population, the intermediate risk population, or the low-risk population. And you can also directly dial in severe cases or like alarming cases. You can dial 911, and then you will access to more urgent emergency attention and health care. So please download it. All of you download it today. Use it. Provide any feedback that you seem fitting, and all of that feedback will be reflected in better decisions by the health officials of our country. Now I would like to say thank you to the fabulous team of the General Directorate of Communications and Technology of the Ministry of Health. And I would like to also thank Emiliano Calderon and his very talented team at the National Digital Strategy Office of the Presidency. And I would also like to thank CONACYT, who has helped us establish a group of specialists of data science and technology. So we appreciate all the collective efforts put to this objective. Thank you very much. Well, today we have seen the closure or the closing of supermarkets. Restaurants are only allowed to sell food to go. A lot of people are scared. They don't understand that they don't understand that supermarkets are still giving service. How can we avoid the population from going into panic? That is correct. Today in Mexico City, it wasn't a general measure in this case. Some parts in the country have implemented different actions that seem fitting so far. We had commented before that the Mexico City metropolitan area, because of being the region with the highest density of infection and the highest accumulated incidents, so the highest infection force, so the Mexico City metropolitan area requires stricter, more energetic measures. And Mexico City governor and the Mexico State governor have been very compliant when it comes to this. So sometimes the population may feel like their space is being restricted, their quotidian life space. We also feel these restrictions because we tried to go to our usual restaurant for lunch and it was closed. So we had to get food by other means. But this is all part of the strategy of safe distance, which is very important that we all abide by. This is a collective effort by the whole society. And let me be very clear again, this is not an emergency state, it is not an exception state. So the Mexican law is very clear when it comes to the conditions under which an exception state could emerge, and this is not the case. These are mitigation measures, epidemiological measures, and we just have to abide by them. The period has just started, the sanitary emergency measures have just started, and they will last until April the 30th, and if we all stay home and flatten the curve and slow down the contagion rate, having less contagions, a lower speed, then we will have a more handleable, more manageable epidemic. We want to say once more that the epidemic is not going to be over overnight, and we have to be prepared for a long-term epidemic, even all the way till August or even September. We could still be having active transmission. But if in this crucial period until April the 3rd, if we contribute as a society and stay home and abide by the measures that have been stated by the government, we will flatten the curve and we will manage better this epidemic. Hello, I come from local media in Baja California. So this intervention is a measure that is being implemented in Mexico City, but what would be the limits of these interventions, of the measures that could be applied by the government? Like in the worst case scenario, what would those measures look like? That's the first question. The second question is, I provided some prescriptions to Dr. Borge from IMSS, and he told me that he would contact the person. Well, I gave this medicine. I gave this prescription to get this medication, and I haven't heard from them. It's been a week, and they haven't been giving us sufficient response when it comes to providing medication, to filling prescriptions. What I'm saying is, like, on the press conferences, all the time you're saying that there is access to health and prescriptions are being filled, but we've seen the reality is quite different. So I would like you to elaborate on that a little. Thank you very much. I think Mr. Cervantes can also comment on that, but we will all work as a team to address that question. Well, and as to limits, Well, the limit is for us to reduce, slow down the contagion rate. We've also said that so this mitigation strategy is based on the scientific data, and what science tells us is it is impossible to end an epidemic overnight. Whoever says differently is lying to you and is not in touch with the proper scientific evidence and literature. So we have estimated, according to different economy and government sectors and society sectors, that these mitigation measures that we have established will be effective because these measures are reducing the daily mobility in the public space by a factor of 70 million people. This all started with the stopping of the activities of school that is now extended one more week. I think all of us should be feeling very satisfied to have such a participative society. It is very stimulating to see all these citizen initiatives that when it comes to communication, when it comes to creative means of staying home and supporting the local economies and creating community networks and facilitating access to information and taking care of our neighbors, of our community. It is very stimulating to see all this collective effort. So I think it's completely out of place to be thinking of needing an exception state because we've had a very good response. And I would like to say congratulations to all of the entrepreneurs and business owners that with great discipline they closed all the establishments that were deemed non-essential by the new strategy. And I want to thank you all for abiding and complying with these measures that are aimed at protecting all of us. Thank you. Araceli, please. So we've been hearing that we've been buying a lot of products that are not high quality products from China, for example, something that we've been hearing about. So, and we know that the Mexican government is going to be buying supplies from other countries. How can we ensure the quality of these supplies? The second question is the COVID-19 specially designated hospitals. Some information has been spread about the possible hospitals that could become the next COVID special designated hospitals. What would be some names that you could give us? Talking about the quality of the supplies and the products, I did see a piece of news by Reuters that talked about in Europe they were buying Chinese supplies and they were saying that they were bad quality or low quality supplies and products. Well, first of all, we don't want to have prejudices based on nationality because as any other country we will find high quality products, low quality products. And I say this because sometimes in the public narrative the Chinese products appear as to be by default low quality, and this is because China is a mass production, has a lot of mass production industries, and this is natural because when you're dealing with such high volumes, if it happens that you have a low quality product and then that becomes news, then everyone starts assuming and generalizing that China is synonym with bad quality, which is not the case. China has splendid quality in some products and splendidly high quality industries. Now we have a set of standards, and these standards have been we have standards, quality standards for these purchases, and they have been based on technique and science. So we have created general groups and on subgroups that whose purpose is to establish the kind of products we need, the supplies we need, and what are the best practices for buying and selecting these products. Now, we have general guidelines for these kind of purchases, but sometimes in emergency situations we make exceptions, and this comes to a cost. This is a risk because we could be compromising the quality of certain products. So because we know that these kind of phenomena occurs when in troublesome times like the ones we live in. So we have created special teams with specialists, with the best specialists our country has, and had worldwide recognition as well, for the purchasing and selection of ventilators, of other important supplies and products. They have a very elaborate strategy of selection, and actually a lot of the products that have been submitted fast test. So the pressure was very strong in fast testing, and everyone was talking about fast testing and why is Mexico not using fast test, and there is enormous supply for fast tests. Like a lot of at the ministry we have received a lot of emails of suppliers of fast testing products. So we contacted the relevant authorities in Germany, and we talked with the people at the Robert Koch Institute, which is a wonderful scientific institute and research institute that has worldwide recognition and has had Nobel Prize awardees, but is also the frame of reference for health measures in Germany. And this institute told us and verified and confirmed to us that Germany is not using fast testing. And Germany, just as a lot of other countries within that region, within Europe, has not recognized any fast test as a useful test for this epidemic. Some other news said that the Agency for Regulation, the FDA of the USA, had authorized a fast test. And what we did is we communicated with the Embassy of the United States in Mexico. We had a conversation with the FDA directives, and they confirmed that the FDA has not authorized any fast test for COVID-19 for the use in this epidemic. We also had a similar search in Canada, and the same thing happened. Canada is not using fast tests. So the World Health Organization has published, it's been available for 3 days now, a technical set of guidelines that says to this day there is no competent, qualified, official health institution that has authorized fast testing. So, mystery solved. There is no fast testing being implemented by any government, and it hasn't been deemed safe or effective by any official authorities. Now, there's been a product that is presented as rapid test that is very technical. From a technical perspective, is the same mechanism as normal test, but that is not a fast test. That is not a fast test. It's a technical difference, but A fast test is different because the reaction test, the normal test that we implement, is a test carried out in a laboratory, and we take so what you do is you take a sample from the mucose, and then you test the RNA of the virus, and you have a chemical synthesis process, and then you multiply this this genetic material, and then there is a detection mechanism of this genetic material. And when you, well, it's a complicated mechanism, but that is the point. That is the reaction test. It identifies components of the virus. But fast testing, the fast tests do not happen in a laboratory. They happen at the patient's bedside, at the hospital, and it's just like a reactive stripe. That basically just changes color at a signal. And what is this signal that activates this fast test? Well, the antibodies. The antibodies that the human body generates as a response, as an immunological response to the virus, will activate this fast test. But this immunological response hasn't been sufficiently studied so we can establish that it's a confirmed and a valid way of testing the presence of coronavirus. So, no. There is no fast testing happening at any government in the world. It's not like the government of Mexico or any other government is against fast testing, but there is no need and no reason to believe that it is useful to use them right now. Now, talking about the hospitals, we are finishing a technical document that would be something like the general guidelines of hospital reconversion. Basically, what this technical document will state is, for the past few weeks we have been analyzing the technical characteristics of a set of hospitals within the whole country. It's been a little hard. Well, it's been a long process for the hospitals outside of big cities, because it's taken a great labor of recognition and analysis, but it's about done, and we will soon have this guide that will allow us to know which hospitals will be used for dealing with the COVID and which hospitals will not. And we already have it, but we would like to make an official presentation, so we will do that next week. All right. 42, 18 minutes to go. I would like to ask you, I read a Harvard publication that said that this could be a biphase virus, and the hormonal aspect of testosterone, or the presence of testosterone could be related to the higher incidence of the males. Also, I would like to ask you about the apps, the app you just presented. There are also other apps of local governments that have been already created. Are you thinking in which one or the other sex have differences in their risk factors? But it is important to consider that the risk is not, the sex is not the most relevant factor when talking about risk. So, for example, with the dengue disease, 2/3 of the cases of dengue happen in males and 1/3 in women, and this is a very systemic pattern. The same thing happens for other diseases. In that, in other diseases, it's even a greater relation, like 75 to 25%, for example. Some of the studies is some of the studies show that it's not precisely because of the sex difference, but because variation in the social conduct within sexes in a given population. So this could be an explanation. This could also be an explanation. I'm not saying what you read about is not correct, but it's a complex situation. It's not only hormonal. And talking about the use of different apps in different states, we'll definitely be in touch, and we are in touch with the developers of different apps that are being used in different states, so we can collect the different data that all of them have been collecting. And yes, of course, it is a great way to have a centralized database, and it is working, and it works greatly to identify, for example, any person who, because of their specific situation, will not go to a medical unit, either because he doesn't think it is convenient or because he is abiding the federal recommendation that if he doesn't have severe symptoms, then he can isolate himself or she can isolate herself, and then through the app they can provide valuable information for us and get valuable information from us to treat their disease. So yeah, this is through the use of these apps, we once again have access to a different kind of vigilance, which is not the hospital vigilance, but we have like self-registry related system of epidemiological vigilance, and this can be very helpful to us, of course. Well, in the sense of having an identification. Oh, it is. If you don't know what they're talking about, well, she asked about código infarto, or like heart attack code, which is a similar system, a communication system, to have anticipated access to medical orientation remotely. So it is similar in that regard to this communication strategy that we are implementing for COVID. As we have said before, one of the main challenges for phase 3 is avoid hospital saturation. So if we saturate the beds and hospitals and emergency room services, that would be very bad. Because of most of the people who get infected with COVID have very mild symptoms that do not need for urgent medical attention. And we don't want to saturate our medical units and facilities with mild symptom or low risk patients. We want to reserve those spots for high risk populations, right? This doesn't mean that there are favorites and non-favorites. All people who live in Mexico have a right to access. Have a right to medical care. It is in our constitution. But in order to make this medical attention more efficient, these apps are a perfect tool to expand the remote medical attention, starting with medical orientation capacities of the government. And also it provides it's a two-way channel of providing information from the state to the citizens and from the citizens to the state. So as you know, there are available numbers to which people can call, and then they can get their doubts solved and get medical orientation and assistance. Deputy Secretary, how is the purchase process going regarding supplies or medical devices like ventilators, etc.? Were you able to secure suppliers or were we late to the purchasing process? And what would be the responsibility of private hospitals? Are they being coordinated with the public hospitals? Because yesterday we heard about a baby who was transferred from a private hospital into a this baby tested positive for COVID, and he was transferred from a private clinic to a public hospital, and I would like to know why. Yes, the supplies topic, I will be providing information about that briefly, because we will be in following conferences, we will be updating all the different improvements in this area. For example, today, this morning, we had a donation, we had a massive shipment that arrived this morning of 50,000 tests, and also face masks and personal care supplies. And these shipments are arriving into our country according to plan, more or less. We have had some complications talking about ventilators, because this is a restrictive supply. But we also found the possibility of repairing some of the ventilators that are currently out of use. We have identified more than 1,500 ventilators that are in existence, but they were out of use because they maybe had a small technical or small mechanical failure. But with the help of engineers from different academic institutions and from the Navy as well, today we have started a very accelerated process of repairment of these ventilators. So this has been a breath of fresh air, because we will have an additional amount of ventilators. And talking about private hospitals, there are 4 levels of escalation. So the first one is talking about the basic conditions of the health sector, talking about beds, ventilators, the presence of a specialized personnel. That is level 1. Now, this infrastructure can be optimized and become more efficient if you implement reorganization protocols without changing the inner structure of the hospital. That would be phase 1. Phase 2 is when you are talking about making calls of postponing surgeries, for example, or postponing other procedures. So you will be affecting the inner structure of the hospital, but always taking care of the patients and making sure you're not affecting the health or the risk of the patients, because there are surgeries that are not urgent and they can be postponed by a window of 3 months, for example. So level 2 is you make these changes. Now, this reconversion process doesn't happen within each hospital in an isolated manner. It's a collective effort of collaboration in which we are providing information and help and support between public entities and from public entities to other public entities and hospitals specifically. So this will allow, for example, we have an IMSS clinic here, and then we have an ISSSTE clinic here, and they're both public dependencies. Well, one of them maybe has more patients and the other one has less patients. So it makes no sense to have that distribution, right? So we can cooperate between these 2 clinics and send some of the patients from one to the other. Now, the third phase is the utilization of infrastructure that was originally not programmed to be used at this time, but that will allow us to expand the capabilities of the health personnel and of the health services at the time. So it would not be surprising if we had to, when phase 3 of the epidemic came, we had to implement things like inflatable hospitals, camp hospitals. Inflatable hospitals are not like rubber hospitals or something like that. These are like, or they're not improvised hospitals. They're planned hospitals that can be set up overnight in a parking lot, for example, or in a designated area. If we don't have to use this, the better for us, but they're also an alternative that we are considering. Now, the last stage is of expansion of public health services is going into the private sector. We don't wanna use the private sector unless it's necessary or unless it's voluntary. Nowadays we are receiving offers of private sector institutions that are volunteering themselves to put their resources to our use. But this is only a voluntary stage. This is only voluntary for the moment, and we don't want to make use of private hospitals unless it's very necessary. Now, a following stage would be the Navy. The Navy and the Army, they already have medical facilities services professionals, and they could also help with the expansion of our medical service. Now, and the next stage is using facilities such as hotels, for example, and then the last stage would be using facilities that have never been used for such things. For example, gymnasiums. But that would be a very, very late stage. Yesterday, you said there were 39 health sector workers that had been infected. Could you update that number? Also say how many are there in Monclova specifically? So can you be more specific at about these cases? How many cases specifically in which hospitals? How many deaths so far? Yes, we will do it very briefly. But we still have 39 cases at the IMSS. Out of these 39, 26 are in Monclova. They're under observation, and three people have died. And one of these deaths happened at the La Raza hospital that you were asking about. The other one was in the Monclova. It was Dr. Reyes. And the other one was in Zacatecas. And just one more thing. I'm talking about the baby. Was that a confirmed case, that baby of COVID? I don't have any information so far, but we can get that information, and we'll talk about it tomorrow. Well, thank you very much to all of you.